Yes, I'm excited. So I'm Uta, and I'm a research facilitator with the Island Health Research Department, and I'm also part of the Embedded BC Support Unit Island Center. And today I'm humbled and most of all very excited to introduce you to Carolyn Variath. And Dr. Variath is a professor at Vancouver Island University at the Bachelor of Science of Nursing program. She is a Michael Smith Health Research BC Health Professional Investigator. Her program of research looks at the ethics of end-of-life care, and her Michael Smith HPI looks at building a compassionate community, a patient-oriented research approach for persons seeking medical assistance in dying. She is also a MAID coordinator with the Island Health Palliative and End of Life Care team. And so I'm very excited to have Carolyn take over and tell us more about her work.
Thanks, Uta, for that introduction. I don't really need to say anything else. So I do want to start off, though, by saying that because of my clinical experience, even prior to engaging in research, I did realize that if we wanted to bring about meaningful change, it has to start and end with patients' voices. And so today, at the conference dedicated to putting patients first, I want to share how that belief is the very foundation of the research that I'm engaged in. And our work is grounded in experiences of people with living experiences, as well as patient partners and community partners as well. So on that note, we will begin. And I might just take a little bit more time than, than Dr. Smart did. Let's see here. Okay, so I just want to acknowledge with a lot of gratitude that I live and work on the unceded and traditional territory of the Snuneymuxw people. So I start there. And Joe, whenever we talk about medical assistance in dying, which is where my research is situated, and I do have to give a little bit of background because not everybody might be aware of it. And so, without going into too much detail, just looking at some of the eligibility criteria. What I really want to focus on is the grievous and irremediable irremediable condition, which is one of the eligibility requirement, and that's then further defined as having incurable disease or disability, being in a state of irreversible decline, experiencing physical or psychological suffering. Sorry, before we get to, let's see, how do I go back on this? So I just want to focus on that particular criteria, the grievous and irremediable condition. To put things in context, most people who come through the MAID program, especially in Island Health, they are track one, which means that their death is foreseeable or that they're imminently dying. So, for example, someone who's diagnosed with stage 4 cancer, those folks are often well supported with the palliative and community health resources available here on the island. But when we're thinking of those who don't have those supports, especially when death is not foreseeable or with someone who's not dying imminently. And if they're experiencing health and social inequities, it might be challenging for them to navigate their health and social needs within Island Health. And so just something to think as we move forward with this work. And so the legislation, because it is MAID is available to people whose death is foreseeable, there is a separate set of safeguards for assessment for those whose death is foreseeable, and that is known as track 1. And track 2 is for those folks whose death is not foreseeable, and they have a different set of safeguards. And so just to give you some context about some preliminary work and all of the work that I've done leading up to the Michael Smith HPI grant has been collaborative and with Island Health and VIU. We had some funding from the Canadian Association of MAID Assessors and Providers, and we did a survey-based study to learn a learning health systems research to understand the MAID program. So we surveyed healthcare providers as well as patients and families who come through the MAID program. We also very gratefully received the C2 grant from Michael Smith, and and we did a patient-oriented research project to understand access-related issues, also to understand patients' and clinicians' experiences with being in the MAID program. And then a small funding from Vancouver Island University allowed us to engage with community partners to understand what supports are available out there and what patients have access to, and how we can better integrate the supports that are available. And so, of course, the patient-oriented approaches, we were very fortunate again to work with BC Support Unit, and Uta is here, and Uta has been very helpful in linking us to the patient partners as well as community organizations locally. And so through those preliminary foundational projects, we were able to survey patients and family members to understand their experiences with the MAID program. We talked to clinicians and patient partners to understand where the gaps were. And then the C2 allowed us to engage with all these folks in a room to really understand what the gaps were and to co-create the program of research that I'm currently working on. So through those preliminary studies, obviously, that we did find that there is misinformation and mistrust amongst the public about MAID, including amongst community support organizations, amongst Indigenous community members, as well as with non-MAID clinicians. Of course, we also identified that there were lack or gaps in support. This includes gaps in access to health and social resources, limited anticipatory care. What that means is patients not being supported, not often. If they're, again, this is not a majority of the case. This is for some folks who don't have access to health and social resources. So they're not supported with preparing for end of life, for example. And then there's also gaps in bereavement support for family members of patients who are in the MAID program. Healthcare providers also shared some of the concerns or their experiences with us as well, including the limited time that they have. Majority of the healthcare providers who engage in MAID-related work, the assessors and providers, that is the nurse practitioners and physicians, this is not their primary role. This is something that they do on top of their full-time jobs as GPs or anesthesiologists or whatever it is that they do. And so they don't have time. So if patients come in who have complex health and social inequities, they often they want to help these folks, but at the same time, they are limited in time and resources. And of course, they also don't know how to leverage the supports that might be available out there in the community. So the voices of the people with lived experiences through these projects were really the foundations for the program of research that we developed from this. And I'm just going to share an excerpt from one of those voices. As someone living with multiple chronic illnesses that leave me in constant pain and existential suffering, I've faced immense challenges in navigating the healthcare system. My experiences have been marked by discrimination, pervasive biases, and systemic injustices, making the task of advocating for my healthcare needs feel both disheartening and unfulfilled. This includes my own experiences applying for MAID, for which now I'm approved and awaiting provision. These challenges have left me feeling undervalued, and I am unable to contribute to society in ways that it expects. In my role as a patient partner, I have had the honor of contributing to some of the projects with Dr. Caroline, helping shape future studies that aim to improve healthcare experiences for others. This opportunity has been incredibly meaningful to me, as now I can contribute to research that will create better supports for those living in similar paths. Sorry. So again, those voices were immensely helpful in bringing about systems level changes within Island Health, but also, as I'd mentioned earlier, in co-creating the program of research, which we will come to in a second. But these initial projects really led to the need for increasing education and awareness about MAID within Island Health. So the MAID coordination team set up some educational sessions for Island Health clinicians, but local community organizations also started setting up community information sessions on MAID. In terms of supporting patients and their families, what we did at Island Health's MAID Coordination Center, the work that we did really informed the establishment of a volunteer program that reached out to family members post the provision of MAID, just to ensure that they were supported with their grief and bereavement needs, or to offer resources that streamline resources to those family members. In addition, we have a standing feedback form now that patients and families can provide us with, and the MAID Coordination Center feedback that we use to continuously evaluate and improve our program. As for supporting clinicians, we did establish some ways to take away some of the work that they're doing. For example, we do help them with identifying patient information. So we collect patient collateral, and that would help clinicians in doing their assessments and such. So these were, obviously they don't meet all the gaps that we'd identified, but this is a beginning. So those research studies and our engagement with people with lived experiences really helped us co-create this program of research. Again, this is the HPI funded research entitled Building Community Capacity to Support Patients and Families Considering and Receiving MAID. So this particular program of research has 3 projects. One is to understand the emotional support needs of families of Track 2 MAID patients. This is different from, potentially their experiences may be different from Track 1 patients, because Track 1 patients are those who are imminently dying, whereas Track 2 patients are those who are not dying but are suffering because of their disease or disability. And then the second project is to understand supportive care needs and available resources to those experiencing health and social inequities who are in the MAID program. And then the first 2 projects would inform the third project, which our goal is to establish and evaluate a pilot community-based peer volunteer navigation program at Island Health. In Vancouver Island, I should say. So this first project is a part of a larger CIHR study. I am the PI of that project is Dr. Barbara Pessett. I am leading this particular study to look at family member experiences with Track 2 MAID. I should say that the development of the study was with patient partner engagement in the form of advisory groups to inform project development, interview guides, and data collection and analysis. We are currently in the recruitment stage, and we have interviewed 15 participants so far. Again, this was informed by a pilot study that was funded by the Ministry of Health. So I'm really fortunate to be part of this incredible group and this team in this work. Project 2, Project 2 has 2 parts. I am just concluding this first a part of the Project 2, which is building a compassionate community. So what we did, this is again a Island Health and Michael Smith funded Health Equity Seed grant. What we did was again, we engaging with patient partners and people with lived experiences in the form of advisory groups to inform project development. The project consisted of 4 cafe-style gatherings across Vancouver Island. Yes, we are currently in the data. So all the 4 cafes are now complete, and we're in the data analysis phase of this project. Again, the participants of these cafes included people with lived experiences, patient partners, Indigenous elders and partners, as well as community organizations. Again, I could not have done this without the help of the BC Support Unit. some preliminary findings, like very clear evidence for this fragmented system that the patients and families are navigating through. And so there might be resources in the community, there might be resources that are offered through Island Health, but there is definitely challenges that patients and families experience in navigating those resources, or even identifying those resources. So just to share an excerpt from one of our patients with lived experiences, when this particular patient was diagnosed with dementia, the path forward felt overwhelming. Understanding which services were available and how to access them was unclear and difficult to navigate. The patient relied heavily on their spouse to advocate and coordinate care and connect them to the essential supports. This experience raised critical question. What happens to patients who don't have a strong advocate by their side? Their story underscores the urgent need to embed accessible systems level navigation support so that equitable care does not depend on personal circumstances. Another ask that came out of these cafes was a somewhat of a directory or a repository of resources within Island. So my students and I are developing a website for that houses service directory for various services across Vancouver Island. So we're in the final stages of fine-tuning this application so it can be sorted by services, sorted by location, and the target audience are healthcare providers, patients, their families, community organizations who can pick up this app and find resources. One of the biggest working as a coordinator, one of the things that patients ask for, or they delay their MAID requests because they don't know where they would, or they don't know, they want to find a home for their pet. And so pet services or pet services is a huge ask from patients sometimes. And so we've got one of those, we've got the pet services here listed here on the application too. And yep, so there's been specific asks. So this was of course developed with input from people with lived experiences as well as community partner organizations, as well as healthcare providers, of course. As for lessons learned, so these photographs are for some of our sessions. Meaningful engagement with Indigenous elders and people with living experiences must be embedded in both planning and implementation. Their insights are really important. For example, seating. We were an Indigenous partner told us that it's better to be seated in a way where we're facing each other rather than an auditorium style or classroom style to mitigate power imbalances, for example. Community engaged forums that fosters trust and reduce misinformation, strengthen coordination. So this is a really good approach to mitigate misinformation and mistrust and to foster collaboration. In the smaller communities that we went to, even though they were aware of the different organizations, even during our meeting, it came to light what resources or services these different organizations offered. So even that wasn't really, everyone wasn't aware of what was really available in the community. But earning trust does take time. It takes multiple meetings. It takes continued conversations and collaborations with patient partners, people with lived experiences, Indigenous elders and partners, as well as community organizations. But to co-create something like a peer navigation program, this is really vital. So I recommend this approach if this is something that any of you are considering. I thank you for the opportunity to present our work here. And again, I could not do this work also without the team that's been helping me with these processes. And I welcome any questions any of you might have.
Thank you so much, Carolyn. Thank you for giving us an insight into your program of research and also just to learn about how patient partners are involved in this program of research. So it's the question period, and we have some questions in the chat. So I'm going to read those questions. One is from Doug, And he says, to what extent might the family members in Project One also identify as home-based informal caregivers? And I think you already talked about that a little bit, the pressures and barriers home-based caregivers face.
Yeah, so many of them are home-based caregivers, and even just working as a coordinator, we do come across the challenges that the caregivers face when they're providing care to these folks. And again, the reason I am looking at this topic in particular is because of the gaps that I identified through my own experiences, but also what we found with those preliminary studies. But yes, they do experience immense pressure. As care coordinators within the Island Health MAID program, we do try and do our best to support the patients and the caregivers. For example, we link them to community health services and we'll refer them to palliative services if the patients meet those criteria. So yeah, that is a very valid question in terms of, and some of them do face those challenges including caregiver burnout. And so figuring out a way to support these patients and families is really important.
Mhm. I've had an opportunity to be part of the rural and remote cafes, and I think it's very interesting to see as you were bringing everybody together, patient partners, community organizations, and clinicians, how siloed people are actually still working, how little people know about the supports that are available. And through cafes and communication or conversations like that, people are going, oh my God, look, this is available for me. I can call so and so. So yeah, so this is these are things that are available for caregivers, and it's I also found it very encouraging that through these conversations, people realize that there were some supports and that more supports will be built around them. So yeah,
Yeah,
but we have
I
another
think
question.
that's a great point there because even through the cafes, just the connections made or clinicians like, oh my
Yeah,
God, you're here, or
yeah.
just them knowing and then exchanging information, even that is just really a big win for
Yeah,
the whole purpose of this, so building that compassionate community.
yeah, yeah. Okay, we've got a question. Thank you for the presentation. Curious as to how broadly representative are the participants. Also, will this work extend beyond island health? So, yes, first of all, how broadly representative are the participants?
Yeah, so I can share with you that within our projects, we've had 15 people with lived and living experiences who were in the cafe style events, and this is not including the surveys, and over 10 patient partners and over 50 community organizations. So that this is specifically about the cafes. As for the surveys, we've had. I think it was over 50 patients and family members who responded to the surveys that we did. So that would be answer to that. In addition, the projects that we were doing with the CIHR funded study with UBC, we're also interviewing applicants and family members, etc. So there's quite a diverse group of people and potentially really well represented for this work.
Yeah, I remember that there were people who supported, so caregivers supporting people with dementia with an interest in MAID, which is another very complex topic. There were people going through MAID that are going through the process. So that was another group. The other group that was very interesting is also the Indigenous elders. I learned a lot of things from the Indigenous elders and how they viewed MAID and the supports available. So I think there's a very broad representation. There was a pretty broad representation across your workshops. Yeah. I'm looking. And then it was also, will this work extend beyond island health?
Yeah, that is the hope. So to implement the peer navigation program, again, this is not new. We're not creating something new. We're basically taking things that have been tried and tested in palliative care. So they're For example, the team that I'm working with at UBC, they've created something called NAV Care that they've used to support patients, palliative care patients who are receiving palliative care at home. So the navigation team offers support in ways of mitigating social isolation or just to navigate health resources in the community. So we do have experts from that team who are involved in this work. There's also a team from Hamilton where we're connected to that are offering peer support groups for MAID-related care across the country. And so when we're implementing this in the communities, we will leverage some of those resources. And the goal is to scale up and beyond Vancouver Island.
Great. I'm looking, I think we have a comment, and this is from Davina Bernard. She says, great to see people with lived experience perspective and MAID research, a much needed perspective. Somebody else, oh, here we go. Apologies, I was not clear enough. Was there representation from racialized to SLBDQ, SLGBTQ, and newcomers, etc., in the communities?
There were a representation from racialized population, potentially to LGBTQ communities as well from the bigger studies. In terms of newcomers, because of the legislation, unless they are able to access publicly funded health care in Canada, they would not be eligible for MAID. And again, MAID access. Yeah, it's just the representations really from people who access MAID within our community at Vancouver Island. And the bigger study has a slightly varied representation, but we are actively trying to recruit to include those folks. But it is challenging though. The recruitment itself is challenging because track 2 MAID is not as common as track 1 MAID in Canada, for example. I think it's what 2% of all MAID provisions is track 2. So there's not a lot. I might be wrong at that number, but it is quite low. And so it is not easy to recruit, but we are trying to diversify our participants.
I had a quick question, Carolyn, about the app because it seems like it could be so useful, and I'm curious if how it's going to be distributed or how you're going to share it and with who.
Yeah,
coming from the knowledge
knowledge broker.
So
the knowledge translation piece is always really interesting to me.
Right, that's a great question. Thank you. It's a website, mobile friendly website. It's not an app,
Okay.
but it should be mobile friendly. So if someone's picking up the phone, it should be user friendly. What we're hoping to do is, of course, share it with the MAID Coordination Center. But the website is really not just for folks in the MAID program because it is for anyone who's looking for health and social resources. So I will. Once it's up and running and once we've fixed it up, we will share it with the broader island health community, as well as anyone who might want to use it. I will share it widely, definitely.
Great. Yeah, I was thinking that when you were talking about it, it seemed like it was for a wider audience. And it's always a challenge is finding the resources that are out there. So that's really useful.
Carolyn, I'm going to ask you one more, and that is you're working very closely with the Island Health palliative and end-of-life care team. So has the involvement of patient partners resulted in any impacts on clinical practice, any changes in patient-centered care?
Well, it's so as I'd said earlier, the folks who are coming through the MAID program, majority of them, we are very fortunate here at Island Health that MAID is very well integrated with palliative services, and so they work really well together. So the MAID program is situated under the palliative end-of-life care program. And so there is a really good integration there. But it has shed light on what is not or where the gaps are. For example, track 2 folks often will not meet the palliative care criteria. So these are things that that are coming to light from this project, or we're becoming more aware of when we're thinking about how to support patients who are coming through the MAID program. As I mentioned during the presentation, we have changed some of our practices within the MAID Coordination Center. For example, collecting collateral information, sharing that with clinicians. There were a couple other things that I can't remember off the top of our head, just to streamline or to improve access to care for those patients. But the fact that the team is involved in all aspects of this project and involved in potentially developing the peer navigation program is also brilliant, because it helps that integration between what's available through Island Health and what's out there in the community.
It's amazing. Thank you so much. And I'm looking at the time, and it's 12:28. So I think it's time to just say thank you so much. Thank you to the presenters for these great presentations. It was awesome to hear about the impact patient partners have on clinical care, clinical practice, your programs of research. Also, thank you to the audience for sticking with us, for asking great questions, and keeping this informative and entertaining. So thank you so much. I don't know if there are any final reflections, Carolyn or Colette, before we part ways. Otherwise, it's lunchtime, I think.
Well, I think we've got to give a shout out to the support units, because I couldn't imagine doing this work without your knowledge and expertise and partnership. So
We're grateful for you guys. That's grateful you're doing this for our communities. It's really wonderful. It's an honor, and it's always humbling to speak to researchers. They do good things.
we try.
All right.
Echo
Thank you
that
so
sentiment.
much, and have a yeah.
Thanks,
Okay.
everyone. Bye.
No problem.
Okay. Bye.